colleagues. My name is Chris Visser. I'm a family physician. I work as a technical advisor for the Foundation for Professional Development. So without any further ado, I would like to introduce Dr. Jose Humawela, who is a close friend and a colleague for many years. I've been collaborating with him on many projects across South Africa. Dr. Mawela is very well known within the HIV medicine space. And is often hosting conferences and also a speaker on many platforms. I'm sure many of you must have seen him before in terms of him sharing his wisdom and his years of clinical experience. He is the executive director for Dr. Mawela Health Solutions. He's a medical doctor, he's an entrepreneur, and also a facilitator of learning that stretches over a period of more than 16 years. He also holds, except for being a medical doctor, he also holds additional qualifications in HIV medicine as well as tropical medicine. He's the founder of Dr. Mawela Health Solutions, a healthcare entrepreneurship firm, and that has given birth to many other organizations such as AQuaH Training School, CliniK TeleHealth, Clinical Care Platform, the Mbombela Women's Clinic, as well as AQuaH Primary Care Clinics. I know Dr. Mawela is a very, very passionate facilitator of learner and mentor, very passionate and fired up about improving the quality care that patients receive in terms of comprehensive HIV care and treatment. So without any further ado, I would like to hand over into the capable hands of Dr. Mawela.
Thank you. All right. So I know that we are going to be doing a number of sessions, including tomorrow when we look at low-level viremia. But for today, I want us to look at an approach for patients who are taking drugs that are regarded as part of our second-line ART treatment, and look at how then, if these particular groups of patients start to have a detectable viral load, how would we then approach them? So yes, as you know, I do know that there are platforms where one must share a lot of studies and try to back up, but I always prefer, practical application because that's what we see every day. And I want to ensure that in the next few days, should you come across a patient who's taking DTG or lopinavir, ritonavir with a detectable viral load, that you practically know how to approach those kinds of scenarios. So yes, it's always good to start with a clinical scenario. So here today we have Kate. She's been taking what we call TLD, tenofovir, lamivudine, DTG. I think they've got emtricitabine, but it's okay for 1 year. Her baseline CD4 count when she was started on this regimen was 156 cells, and the 6 months viral load was fully suppressed. She completed TB treatment, as you see here today. She completed TB treatment last month. Her TB smear at the end of treatment was negative, so we are quite happy that she did well. She attends the clinic today for her 12 months follow-up, and as you talk to her, she does not have any complaints and she's clinically stable. So I would then like to pose one of our first questions. I'm going to launch it myself if it's fine with the conferencing team, and ask you which of these, during this visit, when we see patients 12 months after starting ART, what tests and assessments do we need to do? You are allowed to select more than one option, and we will always give this poll 30 seconds. So you are left with 5 seconds really to fully engage and participate. Let's all participate so that it can be an engaging and fulfilling experience. All right, so I'm going to stop there and then maybe show you, your results and what you're looking at. Most of you are saying yes, at 12 months, we must do a viral load, and equally, we should do a CD4 count and a creatinine clearance. And I think those are probably the 3 tests that we would need to do if a patient presents after 12 months of being on ARVs: a creatinine clearance, a CD4 count, and a viral load. So a viral load is very important because we use viral loads really to monitor treatment success and to detect if patients are not doing well on treatment and if there's a need to review and really consider better regimens. However, an HB would only be done if a patient is clinically anemic and we need to check something, or to monitor patients who are taking a drug like zidovudine. So HBs are not done routinely. Also with your ALTs, it is not a routine test unless if you suspect some liver toxicity or your patient is taking a drug like nevirapine. So for this particular scenario, option A, D, and E would be the test that we would want to do for our patient right there. So the scenario continues with the second question to say you requested the test and the results are back. So a CD4 count is always done at baseline and again at 12 months. And the 12-month CD4 count, you're looking at it there, it's 148. Remember the baseline one was 156. Her creatinine clearance is 80, which is acceptable, you know. Pap smear was also done, which is normal, and her viral load is 1,500 copies per ml. So you then need to advise me what would be your next step at this point in time. What would you like to do for our scenario right there? Now that the results are back, do you want to consider some of the actions you need to do? I encourage all of us to participate. 5 more seconds. Yes. All right. You may select more than one answer if you believe something else needs also to be done. All right. So I'm going to stop right there and then share with you the results. So yes, adherence counseling, you can never go wrong. You know, at any given visit, you know, adherence counseling is very important. It is provided as a support system, but also as an intervention, especially where patients are not doing well on treatment. I'm happy with those who are saying continue current regimen. And the only reason why we want to continue is because this is our first high viral load. So we don't want to rush and start making unnecessary drug switches. Repeating the viral load after 3 months is probably part of the plan. So we would continue the current regimen, repeat the viral load in 3 months' time. And between these 2 viral loads, this 1,005 and the next viral load in 3 months' time, we want to provide a series of support and interventions to ensure that we intervene and we see if our patient can resuppress again. Contacting an expert is never a bad idea, particularly in this scenario, because you have a patient who's taking a drug like dolutegravir and they have a detectable viral load. This is something that we don't expect, especially for someone who's taking DTG as part of their first line, and also it's still within the first year, you know, of taking ARV. So we expect most of our patients to be suppressed. Be wary of option 2 there. You always have to be very cautious and very careful not to be in a rush to intervene when patients have high or detectable viral loads. And also remember the golden rule, which we will still discuss later on, to never switch a single drug when a patient has a detectable viral load. You know, so switching DTG to lopinavir, yes, lopinavir is more robust. You know, it might survive our era in clinical practice, but it is not something that we should be doing. So I hope you are making sense of these particular options. So just to talk a little bit about dolutegravir treatment failure, you know, as a challenge. And it's a challenge because we don't necessarily expect people who are receiving DTG as part of first line to be failing, right? And also we lack really the required history with the drug. to be able to tell exactly, to say if someone is taking dolutegravir and they have a high viral load, are they failing? And you would see later on that even should you detect specific mutations that might be associated with DTG, more than half the time, the clinical significance of those particular mutations, we do question it, so it's actually a challenge when someone has a high viral load on DTG. Half the time, we might not have the confidence to really do something, because we have a sense that it's probably, the first 100 reasons for a high viral load when a patient is taking dolutegravir is adherence. So you have to address adherence 100 times before you can even consider that this is a true treatment failure, So patients who have a high viral load from a dolutegravir-based regimen, we have to assess them by assessing if your patient is struggling to take the medicines because maybe they are experiencing some side effects, if there is food, drug, interactions, especially drug-drug interactions. In my own experience, half the issues we have with DTG have to do with other medicines that our patients are taking, whether they've disclosed to us or not. You might need to assess if your patient has a poor, absorption. Is there a place to do therapeutic drug monitoring, which would then inform you if there's issues of malabsorption or even poor adherence. And then also the timing of resistance testing. So at what point do you then decide to do a resistance test when a patient has a high viral load taking DTG, So this is quite important. And our guidelines do, in a way, also support the idea that patients who have persistent high viral loads on DTG should probably be considered for a PI-based regimen. But remember, just switching regimens does not address any adherence issues that we need to pick up. You would see that in our guidelines, in terms of assessing patients who have high viral loads, we rely on this framework that we call the ABCDE. A, where we assess adherence, issues of side effects, mental health screening, substance and alcohol abuse, where patients have not disclosed, therefore they lack, the adequate support socially. Does our patient have a new infection? Are they taking the drugs as prescribed, or have we prescribed the correct dosages of these drugs? With DTG particularly, I think drug-drug interactions are probably the biggest risk factor which can hamper the effectiveness of this particular drug. Then at some point, we have to have guidelines to say at what point do we do a resistance test? And if we do it, will we be able to interpret it and really make sense of what, the next steps are? I mean, I have spoken about drug interactions. Our patient in this instance was taking a rifampicin-based regimen, which could have reduced the effectiveness of DTG unless if the correct adjustments were done, like increasing dolutegravir to 50 milligrams 12 hourly, and also continuing this induction for at least 2 to 3 weeks, once rifampicin has been stopped. We also need to assess if our patient might be taking some of these drugs. These drugs are now being prescribed for sleeping, sleeping tablets and so on. So drug-drug interactions quite common. Metformin would increase, DTG would increase the blood levels of metformin, which might not necessarily lead to reduced effectiveness of DTG. And everyone in today's world is taking some supplements, whether it's zinc, everyone is so fearful of becoming sick that we are preloading our immune systems with a whole lot of vitamins, but these minerals and vitamins can interact and form complexes with DTG, therefore increasing its excretion and limiting absorption. So this is quite an important slide, and probably for me, one of the biggest risks of putting DTG in harm's way or at risk, right? So in terms of viral load monitoring, right, viral loads must be done at 6 months, and this is a 12-month visit. This is when we are seeing our case, Kate, with a high detectable viral load on DTG. And then following that, we have to do monthly viral loads. Obviously here, the presumption is that you are dealing with someone who's remaining suppressed. Therefore, you would follow the standard follow-up schedule. However, in our instance, our patient has a high viral load, which is more than 1,000, and we have one reading. Therefore, we are not, confident. We are not able to start to play around with drug. You can't do a single drug substitution when the viral load is detectable. And equally, we can't switch to a second-line regimen because you have one viral load, that is high, which is where we were. However, this assessment must be done, A, B, C, D, E, which I have just explained, then repeat the viral load in 3 months' time. So that's why when I asked, what is your plan? Those who said, number 1, continue the regimen, 2, provide enhanced adherence counseling, 3, repeat the viral load in 3 months' time. This would be your key, really, approach to this particular patient, right? But know that this 3 months is not necessarily, enough for DTG. Actually, it might be a bit too early as well, because we know we won't be able to really intervene too early, because we know that, like I said, the first 100 reasons why you have a high viral load on DTG is probably because there's probably adherence issues or drug-drug interaction. There's something to be resolved, not necessarily that we need to be switching. So I'm going to pose the third question, and I'm asking you, with respect to a patient who develops TB whilst taking a dolutegravir-based regimen, what are some of the options that you would have to intervene for this patient? What are some of the approaches to counter the effect of rifampicin on these drugs? All right, so yes. You have a single choice. I think if I had made it to be more than one choice, it would have been a bit different. But yeah, you have a choice. One, what would be the best choice, right? Yeah. All right, it's 30 seconds. I'm going to stop and I'm going to discuss, these results with you just quickly. So this is very important, right? Number 1, switching DTG to efavirenz, it's a possibility, but it's not something that we fully recommend, particularly because your patient would have been on DTG already. We know that efavirenz is the safest drug to give with rifampicin. And if it was a newly diagnosed HIV positive patient who is on TB treatment, then we would recommend an efavirenz-based regimen, mainly to reduce the pill burden on our patient. So the switching to efavirenz or lopinavir, ritonavir, which is that second option there, is not, those are things that are not necessarily recommended. However, it is always recommended that if a patient develops TB whilst taking a dolutegravir-based regimen, that we make a dose adjustment from 50 milligrams daily to 50 milligrams 12-hourly or twice a day. We don't stop ARVs at all. I can assure you of that. So I think we all have some clarity up to there. So I'm going to continue. So here's Kate now. So we asked Kate to come back after 3 months, and she's back now. She's actually coming back after her 3 months visit. So she's still on that TLD regimen. She is well. She's got no TB or STI symptoms. You saw her every week for the first month during this 3-month period. Then you saw her monthly. She attended reliably with excellent pill counts. She denies having any side effects, no signs of mental health or substance abuse. So you'll see that this particular paragraph, it's giving you those answers to the A, B, C, D, E to say it was done and it seems like she's doing okay. However, on further inquiry, she reveals that her DTG dosage was not adjusted with TB treatment, right? So now it could be, it's probably an area of great concern that she did complete TB treatment in the first 12 months of her ARVs, and unfortunately we forgot or we didn't see it, whatever the story is. Now, the viral load done at 3 months, remember the first one, which was done when she was 12 months on ARVs, was 1,500. And then we said, come back after 3 months. It's now 20,000, right? So really, I also don't know what's the plan, but I truly believe that we would engage on the plan. So what do you guys want to do? She's back. 3 months viral load is 20,000. You can select more than one option there, but yeah, give it your best shot. Give it your best shot. I will give you 5 more seconds. Let's try and participate. Your voting is coming in slowly. It might be network issues as well. It's a mixed bag. All right. All right, I'm going to stop it there and then maybe show you the results. So like I said initially, providing adherence is never, a better idea. Should we switch to second line? I mean, that is the big question there. And I also don't know. I don't know, to be honest with you. We will see the next few slides what the guidelines, are saying. Should we do a resistance test at this point in time? Interesting that 53% of you believe that we should do a resistance test. And I tell you what, when we get to, let me not actually speak, we will see in the next few slides, continuing the regimen, repeating the viral load in 6 months' time. And if you look at it very carefully, almost all these options are a possibility. It depends on, your assessment of the patient, your assessment of the reasons why the patient has a high viral load, and the patient is taking a very good regimen. So we are not in a hurry, So yeah, let me stop there. It's quite interesting even for me to say what exactly are we going to do. But if you look at our own guidelines, right? They say when you review your 3 months viral load, remember our first viral load was 1,005. The 3 months viral load is now 20,000. So it has went up 20 times, right? Now you have to ask yourself, which regimen is our patient taking? And now we are on this particular box right there. So this box says, if a patient is taking an integrase-based regimen or a protease inhibitor-based regimen, you must consider switching to second line if virological failure is confirmed. And my question to you is, have we confirmed virological failure, right? Because yes, the definition of virological failure in the context of an integrase or a PI-based regimen, we need to have a viral load on at least 3 occasions over a course of 2 months, of 2 years, right? So our patient has been on ARVs for almost 1 year, 3 months, let's for argument's sake, 1 year, 3 months, and we do have 2 viral loads, we don't have 3. Unless, right, we can confirm immunological or clinical treatment failure, right? So, that is where the issues are right there. So does she meet this criteria? She's not yet 2 years and we have 2 viral loads, but there might be an issue, which is banning. There is a banning platform from this case. The banning issue is the fact that her DTG was not adjusted. I think this is what is making us a bit, shaky and not knowing exactly what is it we must do. Now, regarding DTG failure, right? Regarding DTG failure, which of the following mutations are associated with DTG failure? I want to see if we will still discuss mutations later, but I just want to see, do you know of any mutations associated with DTG. You may select more than one, answer more than one. It's probably an unfair question, isn't it? Unless if you have seen a genotype from a patient who took DTG before for a while. Okay, I'll give you 3 more seconds. Let's all participate. It's always nice when we are all engaged. Yes, yes, come guys. Yes, I can see. Yes, right. It's probably also the network, but I'll share with you the results. I will tell you which mutations are not associated with DTG. K65R is a signature mutation associated with tenofovir and abacavir. And then M184V is a signature mutation associated with lamivudine, emtricitabine, and abacavir. So obviously, your answer lies with the 3 mutations in the middle of the pack. It's either R263 or E157 or Q118R, you know. So let's then do it together. So yes, a number of mutations have been associated with DTG, the first one being R263K there, then G118R, and then E157Q, right? But the question is, if you do a resistance test, let's say for our case scenario, and really the obvious indication for that patient. So number one, if a patient has 2 viral loads, and they've taken DTG for less than 2 years, and this DTG is part of first-line ART, there is no indication for a genotype test, right? We don't do DTG resistance testing when DTG is used as part of the first-line ART regimen. So let's just clarify that, right? However, patients who take a PI or DTG and they are exposed to a significant drug-drug interaction, particularly rifampicin, where the adjustments were not done, that is an indication for a resistance test to be done. And I'm putting this slide to say, if you do a resistance test, right, and these are the common mutations found with DTG right there, you know, what would these mutations mean? Because, for example, 263K, R263K, if it is selected, it leads to diminished viral fitness. So it makes the virus to be less virulent, it replicates slowly. So it's probably it's a mutation like M184V. It's a preferred mutation. It does not necessarily make the drug to be less effective right there, right? If you look at E17Q, you know, it causes low-level resistance, and most patients who have this particular mutation still suppress ultimately, right? One of the mutations which can be a bit significant is G118R, which tends to happen in patients who are given dolutegravir monotherapy, which was not the case. But all I'm trying to get to is that these mutations are there. Half the time, patients are still able to resuppress in the presence of these mutations. And patients do have good clinical outcomes, even when these mutations have been picked up after a resistance test. So a resistance test in that option is something that can be done because we are exposed to a patient where TB adjustments were not done when we needed to do them. All right. So Kate was not switched. The plan was to continue and wait until she gets to 2 years. So here she is. She's now 2 years on ARVs. She's still taking TLD for argument's sake. And this is the summary. Remember, the 6 months viral load was suppressed. At 12 months, we had a viral load of 1,500. There was an 18 months viral load in excess of 20,000. There is a 24 months viral load, which is 16,000, right? But the CD4 count was repeated during the 24-month viral load, and it's 98. She now has a CD4 count of 98. The HB seems okay. Hepatitis B is negative. She's not complaining. She has not missed. So she's still adhering to TLD at this point in time. So having looked at where we are, I wonder if you are going to change your mind at this point in time. I mean, what's your next steps? What do you want to do with Kate? What do you want to do? Now you have 2 years. You have 2 years. Now, some of you are saying she has improved, continue current regimen. You might be fooled by the viral load, isn't it? Because the viral load is now 16,000 from 20,000. Maybe that's why we think she has improved, but I don't think she has. Adherence counseling, yes. Switch DTG to lopinavir. Remember the rule. Remember the rule. We don't do a single drug substitution in this instance. The viral load is detectable, and she has had a detectable viral load for a while. Prescribe a new second-line ART regimen. Yeah. Probably. Let's see if she meets the criteria. But there's things I want you to pay attention to at this point in time. Number one is that she has been on ARVs on a failing regimen for 2 years, right? This particular regimen. It is allowed in terms of our guidelines to get this far, unless if she's clinically unstable. Now, there is no new opportunistic infection, so we are still okay. However, her CD4 count is now 98. Remember, the baseline CD4 count was 156. This particular CD4 count is significantly below the pre-treatment CD4 count. So she does not only have virological treatment failure, she now has immunological treatment failure. So she's got immunological and virological treatment failure. We do not have any clinical deterioration at this point, right? So I tell you, if obviously now she meets the criteria, it's been 2 years, there's immunological failure, the viral loads are still high. So we have to consider, switching her to second line, not necessarily one drug, which is what we wanted to do. But what would be an ideal regimen? So she's taking TLD, and then we now have we believe she meets the definition of treatment failure. Which of these 3 regimens would you recommend for her? All right, let's all participate. 5 more seconds as we all try. You can only choose once this time around because it's a regimen, right? Okay, I'll give you 5 more seconds. Let's all participate. Don't worry, it's anonymous. We'll never see who selected which one. Just have fun and we learn together, all right? Great stuff. So let me show you your results and then give you some tips. Number 1, you must be careful of a single drug substitution. You see, if a patient is taking TLD and you give TL and lopinavir, you have basically stopped dolutegravir and gave lopinavir ritonavir. It's a single drug substitution in a patient who has a detectable viral load, right? Even option C and option D are basically, you're going to give lopinavir monotherapy in a way, because once tenofovir is out due to failure, abacavir equally is out. Remember, K65R would affect these 2 drugs in the same way, right? That first regimen there is like you're going backwards. We never go backwards. Obviously, she has never been on efavirenz before, but she has already failed TDF, and we don't like NNRTIs in patients with the previous treatment failure, right? Now, the best regimen really is to give zidovudine, lamivudine together with lopinavir, ritonavir. You would have given a new regimen with at least 2 new drugs, or 2 new classes of drugs right there. So this is probably the best regimen for our patient at this point in time. Obviously, depending on her hepatitis B status, and luckily her hepatitis B status is negative. So we would really accept that at this point in time. All right, so second line regimens for adults. Remember, this is just to show you, progression, that if a patient is taking efavirenz and they fail, we generally prefer to transition them or to switch them to a dolutegravir-based regimen. Now, our patient is taking dolutegravir as part of a first-line ART regimen. And you can see there's already a caution to say, beware drug-drug interaction every time you use DTG, right? Now, obviously, if we have confirmed treatment failure, she then needs to be considered for a protease inhibitor kind of ART regimen. And there we are, if a patient has taken an integrase-based regimen for more than 2 years, and that regimen is a DTG-based regimen, resistance testing is not required if DTG is used as part of first-line ART regimen. Her hepatitis B status is negative. Therefore, the best regimen is zidovudine, lamivudine, and lopinavir, ritonavir. So this is quite important right there, right? So remember now, DTG resistance, yes, I spoke about drug-drug interactions, but I need you to be very careful. You saw when I showed you the mutations that there is the G118R, that particular mutation is quite common in the context of dolutegravir monotherapy. But I know 9 of us would outright prescribe dolutegravir on its own. So under what context are we talking about DTG monotherapy? I call it clinical monotherapy. What is this concept? And it's my concept, please, I must IP it. Clinical monotherapy. Why would I call it? It's because when you look at the prescription, it has 3 drugs. You have a prescription that has tenofovir, lamivudine, and dolutegravir. On the script there, it's 3 drugs. But clinically, because your patient might have a history of being on tenofovir and lamivudine before and failing those 2 particular drugs, clinically, because of the resistance profile of your patient, you have in essence a prescribed monotherapy. A DTG monotherapy. Another common context is where patients are taking TEE, tenofovir, emtricitabine, and efavirenz, and we say, hey, transition everyone. We've got a better drug, and people with high viral loads, including those which we will discuss tomorrow, with viral loads that are below 1,000 but above 50. The viral load is 900. And you are saying nobody's below 1,000, let's transition this patient to TLD. It's a single drug substitution where the virus is detectable, and some of those viruses might have already mutated, making tenofovir and lamivudine ineffective. Basically, you would have given DTG monotherapy. So clinical monotherapy is where the prescription has 3 drugs, but because of the resistance profile of the patient's virus, only 1 drug is susceptible, which is DTG, and that is what we call DTG monotherapy. So it is a very good drug, DTG. However, we want to protect this drug by always ensuring that we have a strong NRTI backbone whenever dolutegravir is used. If you suspect that your NRTIs are compromised, then DTG is not necessarily the best drug. You should consider lopinavir, ritonavir. I do know that there's recent studies published that are also starting to suggest that that might not be the case, that DTG is as potent as lopinavir, and it should be able to handle, and fully suppress a patient who's got a weakened NRTI backbone. However, our guidelines in the country still do not recommend that you use DTG where the NRTI backbone has been compromised. So please, let's remember that, right? So let's look at quickly the indications for resistance testing in adults. Any adult, right, who's failing a PI-based regimen, a resistance test can be done. Any adult who has high viral loads or failing a DTG-based regimen, right? But where DTG is used as part of second line, this is very important. So first line DTG treatment failure, a resistance test is not required. And really, these particular two cases, it's always a good idea to discuss with an expert of note. And then again, any adult with an elevated viral load on a PI or DTG based regimen, irrespective of whether first line or second line, where the patient received a rifampicin containing regimen and we forgot or we missed to boost the ART regimen. And that is the scenario that we were looking at. It's a patient who's taking DTG first line, but because when the patient was taking TB treatment, the boosting was not done, therefore a resistance test would have been indicated so that we can decide if we need to be changing or even improving the regimen, right? And then lastly, which is also equally important, you know, newly diagnosed. Imagine a patient who received PrEP. Remember, PrEP is tenofovir and emtricitabine, and then they fail PrEP. That means they test positive whilst taking PrEP, right? How sure are you that tenofovir and emtricitabine are still potent for that patient? And if now you have to start them on ART and you give them TLD, there's a very high potential that you'd be giving DTG monotherapy, clinical monotherapy, right? Hence, in our guidelines, it is indicated that if you are going to initiate a new patient who failed PrEP in the last 6 months, it's important that you do a resistance test so that you can determine if you need to use a different or a better NRTI backbone as with the DTG at that point in time. So quite important. This is just my first session to summarize session 1 on DTG failure, you know, to say, remember, adults who are not fully suppressed after 12 months of DTG, we have to do adherence assessments. A few seconds, this thing is appearing again. We have to assess them, review drug-drug interactions, do a viral load at least 3 occasions over 2 years. And if they have met the definition of treatment failure, if they are taking DTG as part of first line, we probably need to switch them. If they are taking DTG as part of second line, we probably need to do a resistance test and then discuss with an expert. I mean, that is really the approach right there. Chris, before I continue, I want to take one question, if there is one question, as I sip my water. Then I want us to look at the second line failure from a PI-based regimen. Dr. Chris, are you there?
Yes, I'm definitely here. Thanks a lot, Lesego. It's been a little bit quiet here. There was a colleague a little bit earlier that has raised their hand. Yes. However, I see the hand has been lowered now. So there's no specific questions that I see from my side at the present moment.
All right.
So unless if there's anyone that would, I do see that one colleague has raised their hand. I will allow you to talk right now. Please go ahead, colleague. You can just unmute your microphone. The one that has raised their hand, unmute your microphone, and then you should be able to engage directly. Please go ahead.
Good afternoon, colleagues. My name is Maidelin Santana. I'm the clinical manager for Johannesburg Clinical Forensic Medicine. We are treating patients with regard to the post-exposure prophylaxis, as you know. So if we come across a case where a patient becomes positive after giving prophylactic treatment after the exposure for 28 days, which will be the best regimen to start on ARV?
Yeah, so as far as I know, because I have reviewed the recent PEP guidelines, I'm not sure the most recent one. For PEP, remember now we are using a triple drug therapy. You know, in the olden days, we would have used 2 drugs, let's say zidovudine with lamivudine or tenofovir with emtricitabine. But as it stands now, for post-exposure prophylaxis, our guidelines recommend a triple drug therapy irrespective of the risk. And one of the regimens fully recommended is TLD, right? So if you look at it, if you are giving PEP and you are using TLD, your patient was negative when you started, maybe after 6 weeks when you retest your patient, they test positive on TLD, right? I wouldn't even change the regimen. You just continue that regimen and then you repeat the viral load in 6 months' time from the time when the HIV was diagnosed. And hopefully at that point in time, your patient remains fully suppressed. So the risk with post-exposure prophylaxis is very low versus with pre-exposure prophylaxis, because with pre-exposure prophylaxis, we are using 2 drugs. So if the HIV virus is exposed to 2 drugs only, the risk of the virus replicating in the presence of these 2 drugs is very high, and therefore mutations might happen, which would weaken our NRTI backbone. So with PEP, you don't have a lot of worries, but with pre-exposure prophylaxis, you do have some worries right there. I don't know, Chris, does that sound sufficient? Yes.
Thank you, Lesego, for that. There's another question from Lungi Kudzwayo, who is asking whether they are allowed to do resistance testing at primary healthcare level, or is that only facilitated through a doctor referral, the resistance testing?
Yeah, so 2 things. One, it depends where you are working, because I'm not sure the audience is probably from all over, the country. For example, with the current national ACC rollout program, capacity has been built for hospitals and community health centers, so CHCs and hospitals. So where there's a CHC and there's a trained staff, the nurse and the doctor are trained, right? They are able to assess patients who are failing second line, request the appropriate test like your resistance test when indicated, and work with maybe an infectious disease or an expert or a mentor or a doctor at an HIV clinic to manage the patient without referring the patient for that particular test. So that is the why I'm answering it this way. For a normal small clinic, what we would call a PHC, 8-hour clinic, this test is not necessarily indicated or required to be done at that level. You might need to refer a patient. However, if you have a doctor who supports you, your mentor, together with that particular clinician, you may help the patient without, avoiding unnecessary referrals for your patient. So, and then I know that different provinces also have different protocols. In KZN, certain hospitals have been designated to run this particular tests and so on. So also check your local provincial protocols, but where there are trained staff, the test could be requested. Yeah. All right. Chris, I may continue then with the rest of the presentation.
Please do go ahead. I'm not seeing any questions at the specific moment, but colleagues that are calling, please do continue in posting your questions on the Q&A. Thanks, Lesego.
In understanding treatment failure broadly, we have to understand how HIV, operates, and it's easier by understanding the HIV life cycle. Remember, HIV has a bilipid membrane, a nuclear capsid, which hosts the genetic material from the virus, including 2 strands of RNA and some enzymes in there. You would see that one of the steps is the attachment of HIV to some of the receptors on our CD4 cells, your CD4 and its core receptor, particularly your CCR5 core receptor, the viral genome after attachment and the fusion of the membranes. The viral genome is then released into the cytoplasm. You can see there the 2 strands of RNA, which are converted to DNA by an enzyme called reverse transcriptase. So it decodes and transcribes a single-strand RNA eventually to a double-strand viral genome or DNA right there. So note this enzyme, which is part of the enzymes brought in by the virus. Now, this double-strand DNA would then be transported into the nucleus, where the viral DNA or viral genome would be inserted or integrated with the host DNA in the nucleus there. And this insertion or integration is facilitated by an enzyme called integrase, right? So integrase, reverse transcriptase, these are enzymes brought in by the virus together with these 2 strands of RNA. Now, the viral RNA would then be transcribed again as part of messenger RNA, which codes for certain nucleosides, coding for certain amino acids that would code for certain proteins, and eventually, coding for the formation of the viruses. Now, there's an enzyme called protease, right? Protease. So its function is to cleave and to cut what we call these multi-protein chains, long strands that are cut, which would then enhance the maturation of these viruses into baby virions. Then they go and infect more and more cells, right? So there's 3 enzymes really: reverse transcriptase, integrase, and protease. And I'm not teaching about the drugs, but I wanted you to appreciate the process and to note that the biggest issues with the HIV virus and its ability to mutate lies with the reverse transcriptase enzyme. And this particular reverse transcription from RNA to DNA lacks this error-proofing mechanism, such that every time this enzyme makes a mistake, it is not detected as abnormal, and it therefore would produce viruses that are a bit different, from the mother virus right there. So a virion, a baby virus, right, has a half-life of 30 minutes. Can you imagine if me and you, we had a half-life of 30 minutes? I'm sure you wouldn't be in this webinar. You would be doing what you have always thought you have been called to do, whether spending time with your kids. If you have 30 minutes to live, what do you spend your time doing? So a virus in 30 minutes, it needs to achieve, its life purpose right there. On a daily basis, billions and billions of baby viruses, are produced. And the 4th bullet there is the important bullet to know that for every 10 to 30,000, nucleotide, this reverse transcriptase enzyme incorporates a wrong nucleotide. And remember, if a nucleotide changes, it means the coding for certain amino acids would change. Therefore, the structure, the ultimate structure of the virus, would change, leading to at least 1 mutation for each viral copy, right? So these mutations happen on a daily basis. And if you consider the amount and the number of viruses that are produced on a day-by-day basis, then you realize that we have mutations ongoing almost every second. Now, if you consider this, therefore, when you have a patient who is infected, with HIV, but not on treatment, they have this huge number, of viruses that are related genetically, but they are unique, and they are called a quasi-species, right? And then each of these quasi-species, remember, they have 30 minutes to do their purpose, their life purpose. So it's all about survival, of the fittest. So each subspecies of this huge pool of viruses has a potential to become dominant, right? And the virus generally with fewer mutation tends to be the one that is favored by the environment and therefore becomes the dominant virus amongst this population of viruses. So if I was to show you here, you've got groups of viruses. This is a quasi-species. You've got your red viruses. These are susceptible, you know, they do not have any significant mutations. In the absence of ARVs, right, your susceptible virus becomes the dominant virus. If you take blood from your patient, you are going to probably draw lots and lots of these red viruses because the yellow ones are not the dominant. They are there, but they are not the dominant because the environment where the patient is untreated and is not on ARVs would always favor the virus that does not have mutations. If you start your patient on treatment, the environment changes. Remember, treatment would easily deal with the susceptible virus. It would become fewer and fewer of the red, and suddenly you get your resistant quasi-species becoming the most dominant virus, right? This concept, whilst it looks easy, it's very important when you want to also to understand when is the right time to do a resistance test and how do you interpret the results depending on whether your patient at the time when the test was done, was your patient on treatment or not? Because remember, if you do a resistance test, when your patient is not on ARVs, the dominant virus would always be the susceptible virus. And your results might come back and say susceptible, but that doesn't mean these guys here, the resistant guys, are not there. They are just being suppressed by the dominant susceptible virus. However, if a patient comes in, they have a detectable viral load and they are on that treatment, even if it's a failing treatment, it would always suppress the susceptible virus such that your resistant bug is maintained as the dominant bug. If you do a resistance test at this point here, right, whilst your patient is on treatment, the likelihood that the resistance test would pick up the resistant bug or virus is very high because your patient is on treatment. So timing of doing a resistance test is quite crucial. And that's why we always want our patients to be on treatment when we do the test, but also pay attention to reasons why patients would have a detectable virus when they are already on ARVs. Things like a regimen that's not properly formulated, inadequate drug levels, like drug-drug interactions tend to affect this, poor adherence and pre-existing resistance, right? Now, just to help you also to understand the mutations, because in the previous session there, I showed you some mutations. I want you to understand where these mutations come from. So firstly, you have to appreciate that HIV is an RNA virus. Remember also our new bug here, COVID, is an RNA virus. We also have DNA viruses, right? Now, this RNA, you think of it as a strand, like a strand, you know, which codes for certain proteins, right, which the virus requires to function. So it has the code, and this code can be translated or interpreted and code for certain amino acids that would then code for certain proteins. Now, on the strand itself, the RNA strand, right, there are codes. These codes are called codons. Remember, a code, it has a message. Remember, whenever you say codon, it means it has a message. So each codon consists of 3 nucleotides. Now, I'm not sure if you remember biochemistry there. You know, nucleotides are things like your cytosine, guanine, adenosine, thymidine, you know, that's why we, you know, so a combination. So each codon consists of 3 nucleotides, and a combination of nucleotides would then code for amino acids. So if I was to summarize it, you've got an RNA strand. On the strand itself, there are codes. Now, this code is made up of 3 nucleotides. When you interpret the code, it will give you a combination of amino acids which would lead to certain proteins. In other words, if the code changes, therefore the amino acids would be different and the shape of the virus would also be different. And that is how basically the mechanism under which resistance happens. When we say there is resistance or there is a mutation, we mean a code on the RNA strand changed, right? Changed, and when it changes, it leads to structural changes on the virus, which could make the virus more potent or even less potent. And whenever you hear of this term wild type, right, these red susceptible viruses are generally called the wild type. The wild type is generally the susceptible virus. This is the resistant virus. This is the wild type. A combination of the wild type and the resistant virus are called a quasi-species, basically. So that is how, that is the language there. So if you look at an RNA strand, it will be a long strand, containing codons, multiple codons, right? You'll see here AAA. So if you've got three A's there, they would code for an amino acid like lysine, GAC, aspartame, ACT, and so on. Now, you can compare these two, right? The first code is still the same. The second code, something happened, right? The G was replaced by A. That means now, rather than coding for aspartame, we are now coding for a different amino acid right there. So therefore, this particular virus has mutated. There is a change in the code leading to a different amino acid, which then would mean the proteins and the structure of the virus would change in that particular space. So when you look at our signature mutation, for example, for lamivudine, which is called M184V, M184V, it means M-methionine at codon number 184 was replaced by valine. So it means here, actually, I think I have a nice example. Yes, you see. So M184V is a signature mutation for lamivudine, emtricitabine, abacavir. If you see a resistance test with this particular mutation, it means at codon 184, under normal circumstances, we should have M there, methionine, right? However, when they now looked at the lab at 184, at codon number 184, instead of finding methionine there, they found that no, it was replaced with valine. So these codes, these mutations have meaning, right? Now, coming back here, if you look at the signature mutation for tenofovir, let's take tenofovir and abacavir. They are generally affected by a mutation called K65R. K65, where's the R? R, there, you see. So it means at codon 65, under normal circumstances, we were supposed to find lysine. But as we investigated and we do the genotype, we find that at codon 65, lysine is not there. However, arginine has replaced lysine. That is the mutation right there, K65R. K103N, K103N. So at codon 103, we were expecting lysine. It has since been displaced by asparagine, right? And right there, that is how you interpret these mutations and how you make sense of these issues, But what is very important is to note that a resistant bug would always, or these mutations would always happen when the virus is allowed to replicate in the presence of the drugs, right? And under what circumstances is this? It means there is reduced drug pressure, either because of drug-drug interaction, poor absorption, increased excretion, wrong dose, wrong potency, poor adherence, right? Leading to a resistant virus. But unfortunately, some patients are very good patients. They are adhering to treatment, but they were primarily infected. They were primarily infected already with a resistant bug. So these are really two primary ways. You've got your primary, resistance. You've got your secondary resistance, which we call acquired resistance at that point in time. And just to summarize some of the mutations, M184V signature mutation for lamivudine, emtricitabine. You've got your thymidine analogs, your TEMs, which would affect zidovudine more than anything. You've got your K65R right there, which would affect abacavir and tenofovir, and then you've got your other mutations, which are not so common, but can still, okay, right? So remember, for your NNRTIs, your signature mutation is K103N, but you can still get your Y181C, Y188C, and so on, which would render the class really ineffective right there. For your protease inhibitors, you've got your V32I, your I47V or A, your V48, and I think that really for me, the last two bullets are my key message to you. Number one is that the presence of mutations against lopinavir, ritonavir, for argument's sake, right, can confer high-level resistance to lopinavir, some mutations. However, these drugs are so potent such that for you to get high-level resistance against your protease inhibitors, you generally need in excess of 6 mutations. And that's why we say our protease inhibitors have a high barrier to resistance, because your NNRTIs, you need just 1 mutation most of the time, and the whole class is out. And here you would need in excess of 6 to 8 mutations to render, high level or complete resistance against those drugs, right? It's also very important to note that when you look at 100 patients, right, you look at 100 patients who present with a high viral load on a protease inhibitor, lopinavir, ritonavir, only about 16% would have at least 1 major mutation, not necessarily even high level or complete resistance. What does this tell us? It tells us that if you have a patient on a protease inhibitor regimen and they have a high viral load, most of the time they are not failing that regimen. It's probably because of poor adherence. They are not tolerating the drug, the diarrhea, which is usually a problem with lopinavir, or even the taste when it comes to children. You would see there were 100 people with high viral loads. Only 16 of these people had some important mutation. The rest had probably stopped taking treatment rather than us saying that they had some high-level resistance. Again, just comparing the different classes of drugs, and you would see that your protease inhibitors are regarded as a class that has a high genetic barrier to resistance. That means it is not easy for a patient to fail this particular group of drugs, and they would require a whole lot of mutations over time to render the class ineffective. Also, a number of studies, 17 studies, and we are just looking at how, what is the timeline? How long does it take for someone who's taking lopinavir, ritonavir to ultimately fail and have major, mutations? You'll see that if you look at it very carefully, it's around 2 to 3 years, right? Most of these studies are around 3 years there, 2 to 3 years. That's when and that's why you'll see our guidelines not recommending us to be switching, patients who have high viral loads on a PI regimen unless if they have taken that regimen for at least 2 years. So it takes at least 2 years to develop some of the major mutations that would render your protease inhibitors less effective right there, right? And again, even when you compare the different drugs by the potency, their ability to suppress the drug on their own against, the genetic barrier to resistance, you'll see that your protease inhibitors will always come out tops. You'll see even on second line, we always say DTG, you need a strong NRTI backbone, but with protease inhibitors, it's not always the case. You can still get away with a weakened backbone because these drugs are very potent and they also have a high genetic barrier to resistance. So they are very trusted in terms of, the regimens that we use, right? But what are some of the reasons, so firstly, the development of protease inhibitor resistance, I think that is the summary really from me to you to say it is uncommon. And when you see a patient with a high viral load on a protease inhibitor regimen, your first suspicion should not be that they are failing. It should be that there's issues that need to be addressed, probably issues around adherence and so on. And the reasons are these drugs are potent, they have a high genetic barrier to resistance, but remember our second line ART regimen has lamivudine there, and lamivudine is known to reduce, viral fitness, and making the virus to replicate rather slow, That is why in South Africa now, when a patient is taking a second line ART regimen, right? Second line ART regimen, and it's a protease inhibitor regimen. We don't just look at the viral load level, right, to decide if they are failing. It is important that a genotype test is done, and in interpreting this genotype test, a score is allocated against each drug that has been tested on the genotype test. And you would see that when you interpret your genotype test, if you see a score of between 0 to 9, it means that drug is still working, it's still susceptible. And therefore, adherence is probably the biggest problem we need to deal with, right? Once it crosses 9 and we get into 10 to 14, we say there's a potential for low-level resistance. So it's not even yet low-level resistance, because low-level resistance, we talk about a score of 15 to 29, intermediate 30 to 59, and obviously, if you see a score above 60, that means there is high-level resistance. That means significant mutations, major mutations that would render that particular drug ineffective have been detected in the virus of that particular patient, and therefore that particular drug needs to be replaced with a better drug. And that is the score, you see, and we call it a PI score. And for someone to even be considered to be failing a protease inhibitor, they need to have a PI score of more than 15. In other words, if someone is taking lopinavir, ritonavir, and you do a genotype test and the result comes back as 12, no, they are not yet failing. It means lopinavir, ritonavir is still very effective, right? We become worried when the level of resistance against lopinavir, ritonavir is way above 15. Then we are quite concerned about our patients. So if you have a patient who has taken lopinavir, ritonavir for more than 2 years, you have repeated viral loads and they are remaining high, right? You have to order a genotype test. And if the test comes back and there's some mutations against lopinavir, ritonavir, and these mutations, the score is below 15, you have to deal with adherence and help your patient to reassess. There is the committee, the third line committee at NDOH would not even look at that case because the lopinavir is still active and you need to address whatever social issues are going on there. However, if your score has crossed 15, let's say the PI score there, the resistance score for your lopinavir, ritonavir is 30, then your patient has failed, and you would refer, and the third line committee is likely to recommend a regimen combination that has these 3 drugs. Firstly, juranavir, which is our best protease inhibitor, with lamivudine and whatever NRTI backbone that is still effective, right? So they'll either get zidovudine, lamivudine with duranavir, right? But before you stop, you have to assess the scores of either your NRTIs or duranavir. Remember, if you keep patients on a protease inhibitor and they are failing for longer periods of time, your duranavir can also start to become compromised, even if they had never taken the drug before. So if on the same resistance results, your score for duranavir is 20 for argument's sake, that means you can't stop here. You now have to add an integrase inhibitor, right? Or if your tenofovir and zidovudine, whatever you're going to use as your NRTI backbone is already compromised, you have to add now the fourth drug, which is an integrase inhibitor right there. Some patients have a triple class, high level resistance. That means they have a high PI score, they have a high NNRTI and your NRTI and your NNRTI, are compromised, and you might need then to add eltraverin as part of, the regimen if it is still sensitive right there. So some patients will get 3 drugs, some patients will get 4 drugs, some patients will get 5 drugs. It all depends on what is the score that has been given against the key classes of drugs that we need to use. So let me show you. Let's do a case. So unfortunately, case, I'm sorry that I kept on, Kate is keeping on coming back, but I think because we know about Kate, that's what we started with. She should give us a sense of what we need to do. So remember now, just to remind you of Kate, she came in, we saw her at 12 months. She had a viral load of 1,500. She was previously suppressed. She was on TB treatment, but we forgot to dose adjust her regimen, right? And then at 18 months, you would see the viral load went to in excess of 20,000, 24 months, 16,000. We last saw her here at 24 months. And she was then switched to zidovudine, lamivudine, lopinavir, ritonavir, right? The problem we have is that 6 months after her switch, she is still not fully suppressed. The viral load has improved. I mean, it's 4,000, more than 1 log drop. So, but we would have wanted her to be suppressed. But she has complained. She's complaining of a high pill burden. She reluctantly reports missing several doses. So, for the first time, it seems like adherence is a big issue. However, she's still clinically, stable. So now, this is a complex case by no means, because ideally, even at this point, you want to discuss with an expert, because it's not a case that you might need to deal with. And if you are working at a clinic, if you do not have a doctor trained on advanced clinical care, it's always best to discuss with your HIV doctor at the clinic or an infectious disease hospital if you have access to such in your province. So let's then discuss this case and see what your options are. If you see a patient recently switched to second line zidovudine, lamivudine, lopinavir, and the patient is not resuppressing, I mean, what do you want to do? What do you want to do at this point in time? Yeah, it's there's no there's obvious options that are very obvious that we won't select. Let's all participate, but there's options that that we should consider in any case. So yeah, I'll give you 5 more seconds because I want all of you to participate. Come guys, let's participate. It helps a lot when you participate. Yes, yes, yes. All right. So I'm going to stop here and then share with you the results. So this is what we are looking at this point in time. So adherence, yes, because she's missing doses and she's complaining about the number of tablets, that there are many. Switching her to third line, yeah, you know, one is starting to think about it, but as to whether the timing is right, I'm not convinced. And then conduct resistance test. Yeah, it's a 50-50 decision, that one. You know, remember, she has just recently been switched. So she hasn't been on lopinavir for more than 2 years, but we know that she has never suppressed before. And maybe there's a drug history we don't know. We might consider it, but I just still think it's too early. Maybe we need to deal with the adherence issues first, and then maybe consider the resistance test later. Continue the current regimen, most likely, and repeat the viral load in 6 months' time, most likely. I think those are probably the two things. We just need to monitor that she does not clinically deteriorate, because the last time her CD4 count was way below 100. So, you know, there are no obvious answers, but there's a discussion that you need to have with an expert, so that collectively you can then decide on what is best for her. So here is her resistance test result, right? So, some of you said, let's do a resistance test, and I said, probably not. That means I wouldn't do it. I would probably do it after 6 months, but there's always a motivation for and against, and that's not the issue really. But let's look at these resistance results, right? So zidovudine, the score is 10. Remember, this means it's low level resistance. It's been interpreted for you. The score has been given. Lamivudine, high level resistance, right? Remember, anything, you know, above 60 there is high level resistance. But remember, this is a mutation that we like, we prefer to keep, because yes, it's a mutation, but it's a mutation that makes the virus to be less effective. It reduces the viral fitness. So we prefer to maintain it. Abacavir, it's low level because of some of these mutations, emtricitabine and so on. But look at your lopinavir there. Lopinavir, ritonavir, susceptible, the score is 0, right? She's got a high viral load, right? Remember, the viral load is 4,000? But the lopinavir score says, no, I am susceptible, right? So absorb these results, because I have a question for you, you know? So you have a patient who's taking a lopinavir, ritonavir regimen, and it is with a high viral load, your resistance test says susceptible, you know. And please, you know, something that maybe I must also help you to interpret with caution, right, is something like what you are seeing there with tenofovir. You must remember what I said earlier. I said, if you do a resistance test and the patient is not taking a certain drug, the resistance test results might not show you mutations against that particular drug. So you see here, the test, I mean, the result says tenofovir susceptible. But me and you, we know that this patient failed tenofovir previously. So why is the genotype saying susceptible? What is going on there? Right? What is the story? The story is simple, is that at the time when the genotype test was done, the patient was not taking tenofovir. Very important to note. If you say, no, tenofovir is sensitive, let's give tenofovir, you'll be shocked to see K65R reappearing right there, and suddenly you have a high level resistance to tenofovir. So that's why you should always interpret a genotype test based on the drug history of the patient and the timing, you know, at what time was this test done, and therefore how do we interpret it correctly. So that is quite important in interpreting. So a susceptible here, you have to interpret it. Don't just say it's susceptible, let's stop zidovudine and give tenofovir. You'll be shocked the kind of harm you would do. So what is the PI score there? So the PI score for our patient is 0. So the PI score is far from 15. So you are not going to refer our case to the third line committee. They will not accept this case because there is no PI score basically in this instance. All right. So the algorithm, you can't even continue, because you can only continue if the PI score there was 15, 20, 30, 40, 60. Then you would continue and decide what kinds of regimens, you know, your patient would be eligible for, right? So unfortunately, no PI score. So let's discuss genotype testing, because it's very important. I tell you, you'll be fighting with the third line committee there, because, and I get a lot of private doctors, especially GPs, calling me and say, hey, I have a genotype test. Can I read it to you? I'm saying, no, don't read it to me. I need more information, the history of the patient, all the drug switches, when did the patient fail, when did the patient start? You also want information about at the time when the test was done. Was the patient on ARVs? Which ARVs was the patient on? What was the viral load? Because these are the, otherwise you want. So the pros is that your genotype test can be used to detect mutations that are causing resistance. Remember, read the sentence fully. On a current regimen. Remember our patient, I was telling you about tenofovir. So it cannot detect resistance for the drugs that the patient is currently not taking, even if the patient had previously failed those drugs, right? Very important. It can also help to conserve treatment options by showing ineffective drugs within a particular regimen. So it can show you which drugs not to use, but a genotype test cannot show you which drugs to use. So please, it's English, but I'm hoping you are following, right? When you do a genotype test, it can only tell you, don't use this, don't use this. It cannot tell you, use this, use this. Going back to our genotype, right? If you look at it, we know that there's high resistance to this one, there's high resistance to that. So we know what not to use, but we don't know what to use, because susceptible might be because of at the time when the test was done, the current regimen did not have tenofovir. Therefore, the genotype cannot measure whether there's tenofovir resistance or not, right? And what are the cons? The cons are that it requires a viral load to be at least in excess of 1,000 copies. Now, it cannot detect also the minority of the variants, right? So if the variants are in a minority in terms of the overall viral population, some of the mutations can be missed, which is quite important, and will only detect currently circulating strains with no information on archive. That's what I was telling you about tenofovir, to say, we know, me and you, from the drug history that we switched this patient from tenofovir after failure. Probably the K65R mutation is stored, it's archived, and it will be re-expressed once we put the patient on tenofovir. An archived mutation will be expressed, and then we need to be able to deal with that. Like I said, it is better at determining which drugs won't work than which drugs will work. As to which drugs will work, drug history, drug switches, current regimen, and you know, so we don't use a genotype test to tell us what to use. We just want to know which drugs are fully out. So that is the key message there, really, from me, right? So so here we are. So remember, we saw her here 6 months ago. It was 4,000. We said no, continue treatment, let's deal with adherence, you know, and now we are at 36 months. You know, her viral load is going up again, which is 36. I mean 13,000, and the CD4 count is 49, right? So remember, when we saw her at 30 months, we did the resistance test and we figured, no, well, now you have poor adherence. Let's deal with your adherence issues. Now, it's 36 months, 6 months down the line, we have repeated the viral load. And look at what's going on. Now she's got oral sores. Presuming this is candida, that means, you know, things are not going well. She seems to be adherent this time around. She's been taking her medicines. She's still clinically stable, but she's got candida. Look at her CD4 count, which is 49 right there. So as we are about to summarize this case, so the first option there, virological treatment failure, I think that one we have had it for years. I think we are just stuck between at what point, do we decide to switch her? So yes, she does meet to a certain extent virological failure, yes, though she's not yet 2 years on a PI, but she's been failing forever. So really she's failing. There is immunological failure. The CD4 count is now 49, which is the lowest ever level. Clinical failure, I believe so, because remember, all along she was asymptomatic, right? She was a stage 1 patient in a way. Now she's developing a stage 3 medical condition. However, clinical failure, by definition, it's not just oral candida. It's defined as the development of a stage 4 medical condition after taking effective HART for at least 6 months. So, she's clinically deteriorating, but not necessarily 100% clinical failure. Poor adherence, still a question. So all of the above, most likely, but it seems like she has changed. She has attended reliably, her pill counts and so on. So there is that element that she's really trying, to do her part right there. So then, can I just ask you, at this point in time, what do you believe is the correct stage for this patient? How would you stage her? Though I think I've given you tips already. What is the most correct WHO stage? Okay. 5 more seconds. It stopped. Okay, I thought I was going to relaunch. Can I see if there's a way of relaunching? But anyway, let's discuss it. It's fine. So just for a few seconds, stage 3 is the correct one. Oral candida, stage 3. She's not yet stage 4. Should be stage 4 if she had esophageal candida. So yeah, we stop it at that. So during these 36 months with this viral load and CD4 count, what is your plan as we sum up this case? What is your plan? What is your plan? Finally. Yes, 10 more seconds as we sum up. Yes, let's all vote. 5 more seconds. Let's all participate. Yes, 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 yes. Let's also participate. All right. All right. I'm going to stop and then I'm going to show you your results because we can only wait 40 seconds. That's fine. So yes, adherence support always. Resistance test, yes. I think, and the reason why I think it must be repeated is the following. The previous one, remember, we sort of thought she had poor adherence, therefore let's continue the treatment, repeat the viral load in 6 months' time. But now she's immunologically and clinically deteriorating. So we need to recheck, because remember, if we don't confirm mutations, we can't refer to the third line committee. So even the refer to third line committee there, it is pending if we confirm that there are mutations that we will pick up. So very important. So I think we will continue the regimen, do the resistance test, then act based on the resistance test results and provide adherence counseling in the meantime. So that sounds like a plan, right? So here we are. So second line regimens. If a patient is taking a PI-based regimen for more than 2 years, in our case, she has taken it for less than 2 years, but she's clinically deteriorating. Her CD4 count is dropping, right? We need to do a resistance test. So now a resistance test is indicated right there. And depending on whether we confirm resistance or not, we will decide. Remember, if we don't find any resistance, we have to continue the regimen, deal with the resistance issues, discuss with an expert and see if we can make the regimen simpler, if there's better regimens, and I doubt really, but we can try, right? And then if there is confirmed resistance, therefore we refer to the third line committee. They would interpret the resistance results for us and then recommend a regimen on a named patient basis. And then we act like that. So here is the resistance profile of our patient. Remember, at the time when the test was done, she was taking zidovudine, lamivudine, and lopinavir, ritonavir. You can see that zidovudine is now intermediate, so she's accumulated more and more mutations. Previously, it was low level. You know, lamivudine is also still a very high level resistance. But look at your lopinavir, ritonavir right there. Lopinavir, ritonavir, now it's high level resistance, right? The score is way above 60 there. So it's high level resistance. We are now very, very worried. And remember what I said, if you keep a patient on a failing regimen for longer periods of time, they accumulate more and more mutations, which would reduce the effectiveness of your other protease inhibitors. You can see there's already a score of 5, even if she has not yet been exposed to duranavir. So this is very important that at the right time, the genotype test is done and the switching has to be done. Not 3 years, not 4 years, but around 2 years. Very, very, very crucial at that point in time. So the PI score is above 15. What do I mean? Because protease inhibitor there, it's 80, right? That means the new regimen would have to be duranavir, which is a new protease inhibitor, plus lamivudine, right? And then we have to choose between zidovudine and tenofovir. Now, that choice is very important because if you choose tenofovir because it's 15, you might be misled by the fact that at the time when the test was done, the patient was not on tenofovir. Therefore, there is an archived K65RA, very high potential for that, right? And your zidovudine right there is 55, so it's quite high, right? So if we opt to give zidovudine with lamivudine and duranavir, right, we then have to assess whether our NRTI score is above 50, and you can see it would be above 50. I mean, above 30, it is above 30 because zidovudine was 55, right? So that's if you give zidovudine, lamivudine, duranavir, you would, in addition, need to add dolutegravir back into the regimen right there. So your patient will be taking 4 drugs, duranavir, lamivudine, zidovudine, and dolutegravir, right? That is how it would work. Then we need to assess if we have a score of duranavir that is also above 15, and luckily, no, the score is 5. So we don't need to add eltravirine, right? So this patient will take 4 drugs, probably duranavir, lamivudine, zidovudine, and dolutegravir, right? I don't trust us thinking that tenofovir will come back sensitive. But if you take tenofovir, you might stop at 3 drugs. But to be honest, my sense is that I would go for 4. And these arguments that I'm raising, whether you're going to give 3 or 4 drugs, we leave them to the experts at the National Department of Health, the third line committee, because these are not easy decisions to take, because you would see that means if you give TDF, FTC, duranavir there, there's no need to continue. But me and you, we know that this is low level, but there's a previous history and a potential for an archive mutation. So these are things that are discussed at the third line committee. So at our level, we don't really engage, we just receive the drugs back. But it's always good to learn and to master the algorithms and know exactly what the third line committee does when we refer our patients. So if it's TDF, because the score is low, 3 drugs are fine. If it's AZT, because the score is above 30, you would have to add DTG, and it's an argument really to be discussed at the high level right there, right? So remember, once you have confirmed resistance, to your protease inhibitor, you then need to complete the form. Please complete it fully, because the third line committee would struggle to engage with your case, because if you don't tell them that the patient previously failed DTG or previously failed tenofovir, then they would make incorrect proposals there. And then we refer to the third line email there, tlart@health.gov.za. And then just to close this session, to say, remember, if we do not switch on time, people end up, failing and becoming sick. They might need to be admitted. But in addition to that, they accumulate more and more mutations, which would compromise, the future ART regimens, and then leading to us infecting more people. To manage a high viral load, always identify the cause, address the problem, repeat the viral load as much as possible, discuss with an expert, and then consider a regimen switch as deemed necessary. All right. So thank you very much. I hope this session was worth your time, and that you have managed to really grasp, how to approach whether a patient is failing DTG or a PI regimen.